So I'd love to welcome everybody to this webinar, our T- Talks, our third T Talks, and we have a very special guest this evening. And our special guest is Krina Panchal, who is a Temporomandibular Disorder Specialist, a TMD disorder specialist. Now, these are disorders that arise from the contact between your teeth, the jaw joint, and surrounding facial muscles that control chewing and moving the jaw. Jaws that get locked in pain, swelling, tender in the face, and also subsequently tinnitus. Now, Krina, welcome. And the first question I have, and we've had so many questions, it's been so popular. I've been shocked at the response. And the first question is, how is it that you have TMJ and how is tinnitus? How are they both connected, please, Krina?
Oh, so basically, I've got my skull here, and I just wanted to just show the close proximity. So this here is your TMJ joint, okay, around here. And where this hole is, where I'm putting my finger inside, that is where your ear is. So you can see how close the jaw joint is to where all the ear bones, any structures in the ear are, okay? Now, also the ear and the jaw share a lot of anatomy. So two of which I'm going to explain.
Yes.
I think they have direct link to each other. So I'll explain a little bit about how the jaw works and then how it crosses over to tinnitus. So we've got two jaw joints, one on each side, okay? Now our joints are made up of the bone, the orange bone that's on top there, and then the white bone that is basically your jawbone that goes all the way around, okay? And then in between there's a disc that's sitting there. So if you imagine, this is the disc, my hand there, and then this is the bone, the white bone just underneath. So this one is called your condyle and this is just called your disc, okay? Now when you open and close your mouth, the disc sits perfectly on top of this condyle, okay? And that allows you to open and close your mouth. Now, when someone is, say, clenching or grinding their teeth, in order to clench or grind your teeth, or not even just clenching and grinding your teeth, if you're biting your nails, if you're sitting like this, if you're having lots of raw foods, if you are biting pens, if you are constantly ripping sellotape off with your teeth, or carrying, lots of people carry their phones in their mouth.
Oh, God.
Because they want to have their hands free to do other things, so they put their phone in their mouth. If you're doing these sort of things on a regular basis throughout the day, you end up fatiguing muscles in and around your jaw. So the muscles that you use to do all of those actions is a muscle that sits there. This one's called your masseter, okay, there's 3 fingers there. And it's basically here, okay, so 3 fingers there. And then a muscle called your temporalis, which basically covers all the orange part of this skull here. So it goes all the way around here and then along into your hair as well. Then you've got another muscle that's more deep inside that actually goes across like that. And that one's probably the most important muscle there as well, where it actually attaches onto the disc. Okay, so when a muscle gets tight in your jaw, you have to imagine that the muscle is a certain length. Say the muscle is this length. When we say a muscle is tight, the length of that muscle reduces, so it gets shorter. That muscle is attached onto the disc that I was talking about over here, okay? So on this side. Now, over here is where your ear is, okay? Now, from the disc to your ear, there's a ligament that crosses over onto a bone called your malleus, which is inside your ear. So you've got the 3 bones in your middle ear. One of them is called the malleus. So the ligament that I'm talking about is called your Discomallio Ligament, and it attaches from the disc to the malleus, right? Now, if one of those muscles is tight, and I said the length is shorter, it then pulls the disc slightly forward, okay? Which then pulls the malleus slightly. Now, it's not centimeters of movement. They're all very, very small amounts of movement. However, the way the three bones in the ear work is that they work on vibrations so that you can hear whatever it is that you're able to hear. When there's any change in those vibrations, you can develop ear type symptoms. So those can be things like not just tinnitus, but muffled hearing, hyperacusis or hypoacusis.
Wow.
You can get a fullness in your ear. You can get ear pain. These are all symptoms that can be produced from your TMJ, okay? That's one way that the TMJ influences the tinnitus specifically. Another way also is all of the muscles in your jaw and in your face really, and in your neck and in your upper back, they all send information through nerves through something called your dorsal cochlear nuclei. And this nucleus sits in your brainstem, okay? And it processes information that comes from your face, neck, and upper back, right? And what ends up happening is that if you've got a TMJ type condition, it could be as simple as tight muscles, or it could be that the disc is going in and out of place and you actually maybe even have a locked jaw. Could be as extreme as that. Plus, say you've got slightly tense neck, it's always tight, you're constantly waking up in the morning and it's a little bit crook, and that's just normal for you. Plus, maybe you've got poor posture when you're sitting at your desk and you've got rounded shoulders, your head's sticking out, or you're always on the phone, or you're doing both. You've got desk work and you're always on the phone in the evening. That basically tightens all of the muscles in and around that area. It also causes a lot of inflammation, and all of that sensory information goes through to the dorsal cochlear nuclei. And the dorsal cochlear nuclei gets very excited and because it's receiving so much information. That will then send information back and sensitize the whole area, so that whenever you have, say, if you're on your phone for even 10 seconds, that's enough for you, the message to go to your dorsal cochlear nuclei, for you to interpret it as, this is increasing my tinnitus, or this is increasing my pain, or this will increase my headache, or this will increase my migraine. So when it comes to treating this area, what I try to do is dampen down the signals that are constantly going there. So we try to treat the TMJ, we try to treat the neck, we try to treat the upper back as well, we try to treat the posture as well, to see if we can desensitize that area and stop the signals from going up towards that area. Now, those are the ways tinnitus is linked to TMJ and the neck from an anatomy point of view. As all your listeners and you would also know, is that there's also things, other things that relate to symptoms like the tinnitus or the other symptoms that I mentioned, like stress, sleep, nutrition, you know, just your well-being in general as well. So all of those things need to be looked at, and I try to look at all of those things to see which has the highest contributing factor to their symptoms.
It's fantastic. I mean, when you're talking, it's exactly when we met the other day. I just think about my own self and my own physiology and skeletal system, and realized that I was destined in some ways to have tinnitus. As I'm talking, I'm aware that my partner's listening, and she is probably thinking about my posture, and I try and do the very best I can. But being a musician, working in those areas of drumming or music or piano, guitar, it's almost a disaster zone, and I'm like this the whole time. And I have a TMJ, and I've had a brace to obviously correct it. So And it has worked. It's brought down the tinnitus. There was the chance of having surgery, but I went to a person like you, Krina. This is why I really wanted to have you on here. And they recommended not surgery in my case, but to really work on the brace and to work on the jaw. So a lot of work is being performed, and I go very regularly, and it has really helped. So another question I have is this. So to start with, because we've had some people that have come in with some questions, and this is one that I would really love to ask. It's very simple, but it needs answering, which is, how can I tell if I have a TMJ disorder?
Sure. I think before I just answer that question, I just want to make a really important point that when I'm treating these patients with tinnitus, the patients I am accepting generally to treat are those that have already been to see an ENT, and the ENT can find nothing. So they've done the scans, they've done all the other investigations that they can do, and they can't find anything. And they've basically just said to you, you know, that you need to learn how to manage it, okay?
Yes.
Now, that tinnitus is called either somatic tinnitus or subjective tinnitus. Those are the patients I'm talking about that I think TMD can contribute to their tinnitus. If on scanning or through investigation, they've actually found damage to that area, I don't think this sort of treatment would help you. So I just wanted to make that.
Yes.
Sorry, what was the question again? I forgot.
Yeah, it's how can I tell if I have a TMJ disorder? How do I tell?
Yes, sure. So actually on my Instagram, which is how I found you guys, I've actually done a TMD checklist.
Yes.
I can send you the link to that and
yes, please.
At the bottom of this. But generally, the best ways to tell is, first, do you have ear pain? Okay, so that would be a lot of people who only have TMD symptoms and do not have tinnitus, they actually present to ENT first because they think they have ear pain.
Yeah.
And the ENT can't find anything. So then they get referred to a jaw surgeon, who then they refer them to me. So do you have ear pain, but the ENT can't find anything? Okay, that's the one way of, the other thing is, do you have muscular pain, especially in the masseter that I spoke about earlier here, in your temporalis? Sometimes spasm in your temporalis here, people think, oh, well, I just have headaches, it's something I deal with. I have headaches and I have tinnitus. But really, they may be linked. So check, do you have pain here? Another way of checking to see if the muscles are tight is actually press into your muscles and hold it. It could be anything from 30 seconds to 2 minutes. Okay, hold one spot, sustained hold. Don't massage around, nothing, just sustained hold. If you're able to feel pain, either locally where you're pressing, or you can feel pain locally where you're pressing plus somewhere else, then I would say that you've got some form of TMD. The other way of looking at it is that when you're opening your mouth, do you think you've got limited opening? Were you able to put a fork full of food in your mouth and now actually you've got to take small bites? Or have you noticed that your mouth opening is much smaller? Also, when you're opening your mouth, look in a mirror and have a look, are you opening straight? So I've got a straight opening and that looks like this. Okay, now some people can open like this. Okay, or to the other side. Some people can also open like this.
Wow, yes.
If you've got something like that going on, then you may have TMD. Have you got a locked jaw? Have you got clicky jaws? Are they constantly popping and clicking? Okay. Other things are, has your dentist told you that you clench and grind your teeth? That's how you usually start developing this sort of condition, that your teeth are constantly together. Our teeth are not supposed to be together. Well, they are when we're chewing, and research has shown that our teeth are only supposed to be together 17 minutes a day, and that is usually meal times, okay? If your teeth are constantly together and you're always clenched, then you have a clenching I wouldn't say it's a problem. Lots of people clench and they don't develop any symptoms. If you clench and you have tinnitus and you have headaches or you've got an achy jaw, then maybe you've got TMD as well. Other things could also be, I think the neck is important as well. You know, have you, like I said before, are you waking up with a neck spasm in the morning and you can't move to one side? Where your hairline is, are you constantly rubbing, putting pressure points in there, trying to relieve the pain that's there? And I think if you look on my Instagram, there's a whole load more. But
yes.
Yeah, but I think some of them might resonate with some of your members.
What is, it's incredible. I mean, what are the treatment options available to all of us in the tinnitus community?
Sure. So I, as a physio, the treatment options are, I always will treat, well, when I see a tinnitus patient, I will assess their jaw, assess their neck, and assess their mid and lower back, okay? And what I'm looking for is there an on-off generally, okay? And by that, what I mean is that I can do certain mobilizations, certain techniques, certain movements, that sort of thing, to see if I can change their tinnitus. Can I switch it on and can I switch it off, okay? And if I am able to do that within session, then I will sort of conclude that their tinnitus is coming from that area. Then when it comes to treatment, I will see, you know, is there anything coming from the jaw? Is there anything coming from the mid back? And may get rid of those areas completely, or most of the time I treat all three areas in one session. Okay, and treatment specifically will, there's a range, you know, I will, if you've got lots of inflammation in an area and you're swollen a little bit, or you've got lots of pain in an area, then I have a laser that I use. So infrared light it basically takes away the chemicals of inflammation away. And before you feel pain anywhere, you have these chemicals of inflammation. You have something called oxidative stress, free radicals, that sort of thing. So this laser takes that away. You can't feel anything with it. It's actually, my patients always report that that's the best part of treatment because it's nice. So there's the laser. I also do something called dry needling, which is same needles as acupuncture needles. It's based on Western medicine rather than Chinese, and it's much simpler than acupuncture. But what I'm basically doing is the muscles that I spoke about earlier that are tight and the length of the muscles has shortened. What also happens on a microscopic level is that the muscles are meant to be in straight lines, okay? And they basically contract together like this. And then when they are straight, they can then effectively relax. Now, when someone has spasm or tight muscles, the muscles are always contracted and sometimes they can be twisted around each other as well. So when you're trying to use that muscle, you just can't come out of there. Now, when you stay in that position, you develop a knot. So the knot that we're always massaging in here, you can develop them in your face as well, okay? And in the middle of these twisted fibers in your muscle, you have a knot there, okay? And so what I do is through the needling is put the needle into that knot so that I can allow the fibers to separate and more importantly, get to a point of relaxation and increase the blood flow into that area so that they are able to be pain-free, less inflammation in that area as well, and use that muscle in the way that they were supposed to use it. The other thing that I do is something called mobilizations as well. So that is, I can do that on your jaw, neck, well, your whole spine really. And the whole point of mobilizations is where you are moving the joint. So it's not like chiropractic treatment or osteopathic treatment where you are cracking and it's grade 5 manipulation. This is mobilization, so it's just shy of that. And the difference is that I am working in the joint's normal range of movement, whereas when you're cracking, you're taking the joint out of its normal range of movement. Yes. I don't think one is better than the other, it's just that this is what I do, okay? And with mobilizations, you can increase blood flow, you can stretch the adjacent muscles around there and just improve the health of the joint, okay? Now, when it comes to TMD, because the disc is sitting there as well, not only are you improving the health of the capsule that is around the joint, but you're improving the circulation that and the nutrients that the disc needs as well. Okay, and by doing these mobilizations, when I told you about how you've got the ligament that attaches over to the ear, when I do the mobilizations to the side, I'm directly working on the muscle that I said is attached onto the disc. And if I can increase that length, it then allows the malleus to sit where it needs to sit and I guess really vibrate the way that it needs to vibrate and take away the symptom of tinnitus. Then I will strengthen the neck and strengthen the back, improve posture, which most physios do as well. So that's a very sort of, I know that was a long explanation, but it's actually a quick summary of what I do.
It's fantastic, Krina. We have some more questions as well. Again, sure. This seems very pertinent also from a personal perspective, which is someone has written in, Krina, and they've asked, my tinnitus changes pitch when I open my mouth wide, like, for example, when I eat, also when I turn my head left or right. Would that be a symptom of somatic tinnitus?
Yes. So it would also be what a symptom of it being related to TMD, because you're opening your mouth. You have to use your jaw to do that. Plus, it the dorsal cochlear nucleus that I spoke about earlier, that comes and all the sensory information from your neck and your upper back goes into there, which sensitizes the area and then creates the symptom of tinnitus. It's related to that as well. So that's a lot of the ENTs I work with. They always ask me, what's the one thing that I should look for if I need to send you a patient? And I said, well, if they say they move their neck and it changes their tinnitus, they need to see a physio.
Yeah.
So it's a very common symptom that patients have.
This is why I went to the orthodontist, actually, because I knew that there was something quite wrong with the alignment of my jaw, and I noticed that when I was biting into even something as innocuous as a sandwich, it would trigger the tinnitus. Strange enough, my tinnitus is in my left ear, yet right. when I strain my jaw, or even if I bite on the right hand side, I don't really have it in my right hand side these days. I've kind of it's gone, but I noticed that I can trigger tinnitus, and it's louder than the actual perceived tinnitus in my left ear. So again, it's when I had the brace, it actually improved the tinnitus by, I'd probably say about 15%, which was enough to then work on that further process of trying to eliminate the sort of troublesome aspect of my own tinnitus. So that, you know, for anybody that's really struggling, having 15% or 10% is easily enough to work on for major improvements, isn't it, Krina? And this is what you were saying, you know, and this is the impression that I get, is that you are really helping people with the percentages, but it's those percentages are absolutely essential to the absolute well-being of that person really struggling and suffering with tinnitus.
So when I see a tinnitus patient, it's a double whammy for them, because not only are they suffering from TMD, they're also suffering from tinnitus. It's twice as bad, you know? And it's a very emotional journey for them. And I always say to them in the first session, after I've done the assessment and towards the end of the session, that if the tinnitus you're suffering with is to do with your muscles, whether it's in your jaw or in your neck or upper back, then I feel confident I will be able to help you somewhat. Now, if it's 100% to do with your muscles, then I think we'll probably get good results. Yes. Like I said earlier, is that there's also the stress element, there's also sleep, there's also your general well-being. They may also be playing a contributing part to your tinnitus as well. So we need to just see how it goes, and then try to address all of those factors. And you know, it's a case of not only me doing hands-on work and me telling them what to do, but also them being ready to take this sort of journey with me, because it's a lot. I do ask a lot of my patients. I try to change their habits, change the ways that they are, their evenings sometimes as well, and their evening routines, because that contributes to how much you're clenching if you're watching lots of TV, for example. So it's a journey that we go on. It's not a case of having physio for your knee, for example, where the physio does lots of mobilizations or something, gives you a few exercises, and then in about 3 months it's done, it's cured. It doesn't work like that. It's a journey that we go on, and you know, sometimes it's successful, and sometimes it's not. So we explore that together.
Incredible. A fantastic answer. I have another one. We've got so many questions, Krina. So little time. It's an amazing answer. I'm going to rewatch this. I'm learning so much from you, Krina. It's fantastic. Okay, here's the question. Is there a typical noise that people with TMJ tinnitus hear?
No.
No.
Tinnitus is, from my experience, and I don't suffer from it, so I can't even say from my experience, but through my patients describing it to me, that everyone presents with so many different sounds. So there's never just one sound that I'm hearing them say constantly. Unfortunately, no. Okay,
yes, thanks ever so much. Yes, I think I would have felt that was a no as well, definitely. I think tinnitus presents itself with so many different sounds, and
yes,
with so many different triggers. For me, it changes as well, or it did change. My own tinnitus is back to pretty much one sound again, but I noticed that when I first had it, I had 8 sounds, and then they turned into 1 sound. But then later on, when I had another accident, it was like knife sharpening. So that was a completely different sound again. It didn't follow any pattern. So again, what I did was I went to somebody like yourself, Krina, and it was so important, because I felt that gave me the confidence, at least, to know that I was doing everything in my power, holistically and physically, to arm myself with everything that I needed in my disposal to try and get the healing process going. And that I felt with tinnitus, when it feels insurmountable, it's so important to try and cover every aspect of your physiology and your physique and your mental state. It's so important to cover everything. We have another one here, so let's have a look. Let me have a look. 1 second. My tinnitus disappears when I'm sleeping and return when I awake. Could this be linked to TMD?
I probably need a little bit more information, but the first thing I thought there was, I wonder whether they are a daytime clencher, or if it's not, and daytime clenching would basically tighten the muscles in the jaw, or if they are a desk worker, what their posture is like. And if it's very poor, then it could be that the neck is contributing to their tinnitus. And if they're lying down, there's no gravity there, so you don't need to use any of your muscles to actually be upright. So when you're lying down, if all the symptoms go, those muscles aren't as tight. They'll still be tight, but they won't be as tight to keep you up. They won't be contracting as much to keep you up. And that's one thing that I'm thinking there. Lying down, I think that's it. Yeah, I probably need a bit more information to see if it's anything else.
Okay, thanks, Krina. We have another one. Are there any exercises that you can recommend for patients with TMD?
Yeah, so if you follow my Instagram, you will see that I have intentionally, and I've thought very long and hard about this, intentionally not put any exercise videos or try this at home videos, because I find that this area is very sensitive. And especially for a tinnitus patient, the last thing we want to do is increase sounds, okay? And also, I wouldn't want someone to exacerbate their condition, because sometimes that is what happens when you have physiotherapy for any area, is that we can exacerbate your condition with the long-term goal of it actually bringing it down. And I wouldn't want to put someone off trying these therapies just because maybe they've done it in a slightly wrong way or pressed harder than they should have. However, I say this, but today I have just posted a video which I feel confident with, and I've given lots of instructions. Again, it's on my Instagram, but I'm basically using this device. So I've done lots of research on this, not clinical research, but basically given it to my patients, tried it on myself for a few months to see how much relief you get. So it's basically trigger point release, okay? And what I get people to do is, you'll see in the video, maybe we can post it on here as well, but find your oh God, I know the clinical name, hold on, your cheekbone, cheekbone, find your cheekbone and put this device on there, okay? And then you bring it down. So if you haven't got this, you can use your thumb or your fingers as well. But I just find that this is better than using your thumb and fingers, because thumb and fingers can get tired after a while. Find where your cheekbone is. Just go down, come off the bone, and you'll hit a muscle, okay? Now, what I want you to do is do a sustained hold. Don't move around, just a sustained hold. Let the pain increase, then let the pain decrease. Now, the hold may need to last for up to 2 minutes, okay? So it's a long time. Now, I know if I press there, I can feel the pain instantly. And I work on this area all the time, so mine is already decreasing. But for most people, you need to hold it for a long time. Then you move on to another area. So if you're using your thumb, the same thing. Press, let the pain increase, let the pain decrease, and then move on to the other area. You can also do that in your temporalis area, the exact same concept. And you can also do that in anywhere in your neck. And it's really simple. Let the pain increase, let the pain decrease. And what you're doing by letting it increase and decrease is you're deactivating that trigger point, that knot, okay? And if you deactivate it, it will then cause less symptoms and stop bombarding your brain with signals saying there's something wrong with me, and produce all of these symptoms. So that's one simple thing that you can do. Anything else, I generally don't like to say, because I find people do it wrong, and then it can be a negative impact. So.
Thank you very much, Krina. We have another question now, and this one is, my tinnitus seems to be linked to my jaw joint.
Yes.
It is worse when I close my mouth. I did have radiotherapy in this area 25 years ago. Could that be why this is happening?
Yes, so when you have radiotherapy to that area, it's well known that you end up with smaller mouth opening, because it destroys the tissue within your mouth, and therefore there isn't any nutrition left there for the fibers to be, to contract nicely and separate nicely, and they just become all shortened and stay that way. So I assume this person has got quite small mouth opening, and if that is the case, then it would then contribute to their TMD type symptoms. So yeah, I think there's definitely a link there, and something I hear over and over, not because of radiotherapy, and that does cause it, but more because they've got smaller mouth opening for other reasons, and that will then produce their tinnitus.
Wow, great answer. Another one, I can increase my tinnitus by pressing on my temporalis, and I've now developed clicking in my ears related to movement of my upper palate. Could you advise on that clicking? I also have bilateral somatic tinnitus.
Sure. Does it say if she has a clicking on both sides or just one?
It says I've now developed clicking in my ears, so I'm guessing with the with S at the end of ear, then it's both. Yeah,
Yeah.
I'm guessing. Yeah.
Okay, so again, I think back to the disc, condyle. Now, when someone is clicking, usually what happens is that the disc is slightly out of place. So rather than sitting perfectly on top of this condyle like this, is usually slightly forward. So when you try to open your mouth, you basically click onto the disc, or you click off the disc. You're clicking somewhere on the disc anyway. And that is the sound that you hear, the click. Okay. When someone is just clicking and it hasn't changed their mouth opening, it just basically means that the disc is slightly out of place and you're just clicking on and off it. Now, if the only symptom you have is clicking, I wouldn't even see a patient that only has clicking, because it's not sinister. It's like having a clicky knee or a clicky ankle. You know, if you have no other symptoms, there's no point in treating it. It's only when you have other symptoms like achiness, reduced mouth opening, or tinnitus, neck symptoms as well, that would I then start looking more into that. But the aims of treatment would not be to reduce the clicks, even though they can be a bit annoying, because we may not be able to change what the disc is doing. Once the disc has degenerated to a certain extent, you can't reverse that unless you have surgery. And you shouldn't really be doing surgery on just a disc that clicks. It's unnecessary. So we would treat all the other things around it. But yes, that can produce the tinnitus, because remember, the ligament that's attached onto the disc. So if that disc is sitting in a slightly different position, it's stretched that ligament that's on the malleus.
Wow, that's incredible, incredible answer. We have another one. Okay, another question. I've had tinnitus for 10 plus years. I was in a car crash 18 months ago, and around about 9 months, my tinnitus has worsened considerably. The ENT gave me no avenues to explore. My tinnitus has always been somatic. I can change the pitch with my jaw. Also, I experience jaw aches from time to time. Could TMD stroke TMJ treatment still be something I should explore?
I think so. I think so. With all the things that she's explaining there, to me, it seems like, you know, she may have had a little bit of whiplash, which puts the dorsal cochlear nucleus on fire. So she's got that, plus she's got the TMJ condition. So yeah, I definitely think she should explore it. And I think it's also important to note here is that just because I'm speaking about this doesn't mean it's something that is popular and is well known. A lot of ENTs, the reason why they may not have referred you to someone like myself is because in the UK, there aren't that many physios that specialize in this area. Because in physio school, I know that I wasn't even taught the jaw joint. So I didn't even know really what it was and how complex it was. So you really need to go down specialism and go to different countries to learn this and then bring it back. So if an ENT hasn't referred you for something like physio, is more because they don't even know that it exists, that they can even refer on. So when I've spoken to ENTs and I've said, you know, maybe I might be able to help, they're always really thankful because they too want to help you, but they just don't have the means to do it. Okay,
that's fantastic. We have loads of questions. We have another one, Krina.
Sure.
Okay, I have TMD confirmed and a dental splint to help. I have bilateral tinnitus and recently developed a clicking related to my upper palate. Have you come across this before? I can control the clicking and it also happens randomly.
Like I said earlier, clicking on its own, I mean, she has TMD. I would say similar answer to the one said last time. If she's clicking, the disc is out of place and therefore it's changing the malleus directly. plus the tight muscles. So I think it's probably the exact same answer as the
yes.
Yeah.
Okay, that's great. Okay, I'm being asked, what should people be looking for if trying to find a physio like yourself to treat them, please?
So maybe we can link it in the bottom again.
Yeah, definitely, Krina.
There is a association called the Association of Physiotherapists Treating TMD, and it's a website. And on that website, you will find a practitioner and type in your postcode and see who's local to you. Now, these physios, I know the people who set it up quite well, and they are really fluent in TMD. They may not be fluent in treating tinnitus, but they are fluent in treating TMD. So I think it's so worth going to see them, because really you want your TMD treating and your neck treating as well. So I think they would be able to help you. And they're training up quite a lot of physios. And I guess, you know, if you needed more specialist care than that, then, you know, feel free to contact me.
That's fantastic. Yes, we'll certainly be giving your details. Absolutely, Krina. I have a question myself here. What is the function of the trigeminal nerve? So
basically, it's a nerve that serves your face, head, neck region, and it's got lots of branches. It has one branch that goes to the ear. There's one branch that actually serves the jaw, but then some of the branches actually cross over and serve the ear and the jaw. And then other ones will serve the neck, so other ones will serve, the eyes, other ones will serve towards the neck. So there's lots of branches, but it basically gives sensory and motor information to your brain to say, well, if I open my mouth, that's actually, all those signals have gone through my trigeminal nerve and told my brain that I've just opened my mouth. Okay, so that's what that nerve is.
Okay, that's lovely. And can that nerve heal itself? Is it possible?
So when someone has trigeminal neuralgia, which is a condition that you can get, and this is basically getting pain in the distribution of where the trigeminal nerve serves. Now, there's a difference between TMD and trigeminal neuralgia. They're completely two different things. They come under the branch of something called orofacial pain. But when it comes to the symptoms, they are completely different. So because TMD is more muscular, the pain is more dull, ache in the background. Just sort of, patients are usually reporting that it ranges from 2 to 7 out of 10 with pain. Whereas when someone has trigeminal neuralgia, it's sharp shooting, throbbing, invasive, can't get away from it. It's things like wind blowing on your face, accident, you know, just even touching your face like this can just set it off and it's on fire. And they are reporting pain that is about 7+ out of 10. I mean, a lot of them will even say it's actually 12 out of 10 because it's off the charts. So I don't treat trigeminal neuralgia. I don't think there's much evidence based between for physio and trigeminal neuralgia. So I know I can't treat it.
Yes. Okay. Thank you. Is there any of this support available on the NHS? And if so, could I get a referral from my local dental hospital to see you?
Unfortunately, I don't work in the NHS.
Yes.
Not out of choice. I would love to set up a clinic in the NHS. So if anyone is listening and they have the means to set this up, then I would love to speak to you, depending on location. So I only work privately, so unfortunately not. However, it's probably worth getting in contact with your local maxillofacial surgery department and seeing if they have a physio that's trained up in TMD, because the ACP TMD, the website that we linked earlier, a lot of NHS physios train with them. So you may have, they may not be advertising it, so it's probably worth just maybe giving even the physio department a call and say, do you do this?
Okay, that's lovely. It's lovely. We have another one here, which is, where is it now? It's another one that's just come in. I just had it here. How can I prevent TMJ disorders? So is there anything that I can do to kind of stop the from stopping it from happening? Is there anything I can do to really do my best to stop this from happening?
I think maybe if you watched the video that I mentioned earlier about, I think I call it the 10 signs you've got TMD. If you watch that video, on that video, there's lots of habits that people have. For example, like I mentioned earlier, biting your teeth, sitting like this, having poor posture, that sort of thing. I think if you stop doing all of those sort of things, then you're less likely to really present to a physio, to be honest, or have to go to a dentist for a mouth guard.
Yes. Okay, we have another question. I don't think we'll get through all of them, Krina. There's so many. I have private healthcare via Bupa.
Mm-hmm.
Is this the kind of treatment that they might be able to cover?
Yes. So I have, I'm registered with Bupa. And so, yeah, you would be able to come and see me and it'd be covered fully.
So, for example, for myself again, because, you know, I had the brace, I had the chance of having surgery, I went to a chiropractic, it wasn't the same. A very, very highly recommended, very trusted chiropractic. They suggested to not do that, I shouldn't have the surgery. I had, I guess, my jaw wasn't aligned properly. I think it was through birth. I also had a horrendous accident with playing in goal, so that didn't help. I also lean like this, so everything was in its against me, really. So there is so much that you can do even without the surgery, because we've also had people, we've had 3 people that have written in this evening that have said that they have had surgery and it hasn't worked. And I was warned about that myself. And I'm not saying that we shouldn't have surgery at all. I'm just asking the questions. But I know for my own self, it was a choice I had to make before I committed to the brace, which I had. But it meant that the brace would be a different kind of treatment. So is that possible then, that if you had a little bit of that bone chipped away that was obstructing, is it possible? And in a way, how could it go back then if that bone was missing? Is it just that the jaw sits naturally in its own place, and it has done for many, many years since you were born? Is that kind of what happens? Or is it, like you're saying, is it the muscles that are keeping it there? So the work you would have to do would almost be insurmountable. So is it a question of just trying to maintain what we have? Is that the idea, through the manipulation and stretching and warming that area and obviously massaging it and all the work that you're doing? Because I still have in the back of my mind, I think, should I have had the surgery? But I'm quite glad I didn't, purely because where it was right where my tinnitus has been over the years.
So it depends on what sort of degeneration you've actually got at your jaw joint. But I would say, just generally, for most cases, I always work alongside a maxillofacial surgeon. So I'm always getting their opinion on whether they even think physiotherapy is going to work for these patients. And most of them will say, well, you know, what's the worst that can happen? Because physiotherapy is non-invasive and it's reversible. So, you know, I'm not injecting anything into you. I'm not doing surgery, you know, I'm not doing anything like that. So what's the worst that can happen? But from experience, when someone has come in and they actually have a bony deformity, I have been able to increase their quality of life. So I may not, because if something happens to a bone, it's stuck there. There's nothing a physiotherapist can do to change the orientation of a bone, the shape of a bone. You know, you can't do anything with it. We can change soft tissue, which are your ligaments, tendons, and muscles, and your disc. So, and your body has an amazing ability to adapt to the environment that you are in. So even if it's not ideal, maybe physiotherapy can then get you to a point where you're adapting and your quality of life is improving. Maybe your tinnitus is decreasing as well. And I think we can get you to that point.
I think, yeah.
Deformity that's happened.
I think that's definitely been my case, Krina. Yeah. I feel very comfortable with the treatment I've had. I'm really glad I went for that option. It really worked. And my tinnitus has dramatically decreased over the last years with the therapy that I've undergone, and the sound therapy, and I go to see a chiropractic every 3 months actually.
Right.
And she's amazing, a woman that's in Wootton on the Isle of Wight, and she is a cranial expert with chiropractic, and it's McTimony, so it's not kind of the bone crunching. So yeah, it works really, really successfully. We have another question here. We've got another 3. I think that's probably all we've got time for, Krina. I had a splint made to deal with possible grinding, but to no effect. And I've also been to a chiropractor, but clicking my neck one way or another did not seem to be productive. The nighttime in bed ramps things up. So I think that there is a mechanical neck issue down to arthritis, possibly. What do you recommend regards bed and sitting down?
I've actually got a really interesting patient
yes.
who complains of exactly the same thing. What I'm finding with patients who have an increase in tinnitus when they are lying in bed is the first thing I'm thinking about is your pillows, and how many pillows do you have? So pillows are only supposed to be there to provide cushioning in the gap of your neck. So your neck is slightly curved, it's not straight. So you just need a little bit of cushioning so that you can provide support to that little curvature. And then therefore your head sits straight onto your neck and your shoulders. If a pillow is really high, i.e. you have 2 pillows, for example, and your head is like this when you're lying down, or your pillow is too low and you're all the way back like that, that's not enough support for your neck. So for this patient in particular that I was speaking about, for him, he had too many pillows, and by taking away the pillow, I'm still treating him. So I need to see if that's making a difference. But the first night he did it did actually reduce his symptoms. And for the first time, he didn't wake up in the middle of the night because of tinnitus. So that's the first thing I'm thinking with pillows. Also, you know, how supportive is your mattress as well? And if you're only getting it at night time, then yeah, I think probably more pillows and mattress really.
That's fantastic. Yes, pillows. That's surely an experimentation for myself at the moment, because I had a nasty chest infection last year, and so it stayed with me for quite a long time. And I'm sure a lot of people have had the same kind of issue, which is you increase the pillows so that you can get a good airflow, so you're not having some kind of sleep apnea, or you find yourself choking in the night. So yeah, I'm back now where I feel so much better. So I'm back to my 2 very shallow pillows, which is just wonderful, because I noticed that certainly changes my feeling about my neck and my back and pain. Yes, yeah. It has a huge effect, doesn't it?
It Absolutely. Does, and it's really surprising actually. And all of these things you don't really learn on a course. You only learn these things from your patients. And I think that's what's so, for me, treating these patients, a complete pleasure, because I learned just so much from them. And they are the experts in their own condition. I'm just someone who can help maybe piece it together. But Yeah, usually the patients know what the answer is and they tell me all the right things, so I can say, well, I think maybe it's this, this and this, and then hopefully I can help them.
Fantastic. We have two last questions. If we can, let's see. I mean, if we can only answer one, it's fine, Krina. It's been absolutely mind-blowing. Please, my facial pain clinic have tried me on various drugs for my TMJD, duloxetine, amitriptyline, baclofen, and now gabapentin.
Yeah.
None of these help. Are there any medications you do recommend?
I can't recommend medication because I am not a doctor. So I can't recommend the medication, but a lot of my patients are on amitriptyline. And if they've got nerve pain, then gabapentin is used as well. A lot of them do find relief from taking those medication. Amitriptyline used at a low dose is a muscle relaxant. At a higher dose, it's an antidepressant. And usually TMD patients are given it at a low dose so that they can relax the muscles. But then there are lots of patients I have as well that amitriptyline isn't working and therefore they need the physio too. So I'm not really answering that question fully, but I actually can't recommend medication, unfortunately.
Yes, thank you for answering that, Krina. The last question. My chiropractor suggested I had a condylar jaw jump, which could cause my tinnitus. Is this something oral and maxillofacial could help with? The chiropractor works on my muscles but doesn't give me much relief, although my jaw opening range has improved.
So I would say, again, I probably need a little bit more information about what's actually going on with their jaw joint. Oral maxillofacial surgeon, I think generally should always be involved when you're treating a jaw, even if it's the sake of saying continue with your chiropractic treatment, just because whether you're a physio, chiropractic, osteopath, any of those professions, we're not trained enough to actually know, is there anything more sinister going on with the jaw joint? We can't take scans, we generally don't interpret them. So it's always good to have them on board. There's no harm. If you've had increase in range of movement, but actually haven't had a change in your symptoms, I wonder whether you need some exercises to strengthen that area, because what I usually find is that if I'm constantly doing loosening off work and loosening the tightened muscles, I reach a plateau where they just don't get better. And really they need, and I've learned from experience now, and I never do this, that I give them strengthening exercises. So then they can maintain their own condition, and you don't have to keep on coming to see me. So I generally will see within about, say, I don't know, about 3 to 5 sessions, I have good results with my patients. If I'm getting to 10 sessions and I'm not resolving a lot of your symptoms, then really I would start questioning, what is the use in seeing someone that isn't relieving your symptoms, really. Usually, especially with physios, we have this rule of seeing someone 6 times, and if you're seeing them more than that, then you need to start questioning who else should they be referred to, what are you actually doing. There's no need to see them on numerous occasions over years, unless you're doing maintenance. If it's worked and you're doing maintenance, then yes, fine, but not for your first time. You shouldn't be on 20 sessions and no change.
Yes, thanks ever so much, Krina.
No
we'll talk again after we've said goodbye. We'll send you a message because we want to personally thank you ever so much for being here tonight. I'm absolutely gobsmacked, and I've learned so much, and I would actually really like to pay you a visit sometime, actually, because it would be really great just to be able to just say thanks ever so much. But just on behalf of all of us, Krina, Thanks ever so much. Wonderful. It's really brilliant that you've given your time so freely. Thank you, Krina.
No problem at all. It's actually been a pleasure, and I've had a lot of fun doing this.
Thank you, Krina, and goodbye. And
Bye-bye.
goodbye, everybody. Thank you again.
Bye, everyone.